Ask you this. I want to get into some of the screening things because screening is certainly so paramount when it comes to lung cancer. So I reconnected with Dr. Zerlandis at a Loyola conference back in April, and she gave an amazing talk about lung cancer because that's really her forte. But she's got a forte in a lot of different things related to oncology. But I thought one of the striking points that I took home from her lecture was the screening modalities that are out there. And certainly as a primary care physician, I left that conference and I said, wow, I need to do a better job looking at the guidelines for screening for lung cancer. So, Doc, you mind telling us a little bit about what are these guidelines, a low-dose CT scan? Can you explain a little bit to people that are listening to the show, what's out there, when is it indicated, and what are we trying to accomplish? And are we accomplishing what we're trying to accomplish?
Great. So, lung cancer screening is something with which I'm intimately involved and something that I think is very important. Low-dose CT scans, so CT scans that are done with lower than conventional use of radiation, has been shown to be a tool that can help diagnose lung cancers earlier than usual. So we know that outside of a screening program that most lung cancers are diagnosed when someone would present with symptoms, so a cough that won't go away or shortness of breath or whatnot. But what we're trying to do is see whether we can diagnose lung cancers much earlier on, perhaps when there's just a small, isolated nodule that's a lung cancer in the chest, rather than something that spreads and causes symptoms. And so there was a large clinical trial that was published about 6 or 7 years ago that showed that compared to getting chest x-rays, that doing a low-dose CT scan in patients who were at high risk for developing a lung cancer was associated with a 20% decrease in the chance of dying from a lung cancer. So we're still finding lung cancers, but we're diagnosing them earlier. And the high-risk population that we're trying to target is persons who either currently smoke or have quit smoking. And we try to target patients. There's a couple of different guidelines, but generally patients between the age of 55 to 80, persons who don't have any symptoms, so someone who's just coming in for a screening test would be someone who wouldn't have any of the other symptoms that we talked about, someone who has an average of a 30-pack year of smoking history, so that is on average about 1 pack per day for 30 years, or more cigarettes per day for a shorter period of time. And then either someone who is still smoking or someone who quit smoking within the past 15 years. So we know with any screening program, we're really trying to target a high-risk population. So those people who are at the most risk stand to benefit the most from a screening tool. So we're trying to really find persons who don't have any symptoms. And of course, we never want to find the lung cancer, but if we do, the chance of finding an early stage lung cancer that can be cured is much higher in the setting of screening. Cancers that have spread, or metastatic cancers that have spread from where they started, that's where our treatments really have grown over the past 5 to 10 years. Coming out of fellowship, there are treatments that I'm using on a near daily basis now that didn't even really exist or weren't even on the landscape 10 years ago when I was coming out of fellowship. So it's really an exciting time to be a physician treating lung cancer because we've made some really great strides, and I think that's an excellent point about trying to infuse both hope and money into funding to try and really try to find more cures and to help patients live longer and better lives.
I think one of the great trends that I'm seeing, and as a primary care physician, certainly by the time we make these kind of diagnoses, certainly they're working with you guys as medical subspecialists. But I just really am very hopeful about the technology as it's evolved. You know, going from very more of a kind of a one-size-fits-all approach to cancer treatment to very getting down to specific at the molecular level of specific targeting of therapies. And as you're saying, it's like some things that you were doing, you know, when you were in fellowship, it's completely different. And things that maybe used to be experimental back then are now more commonplace and much more attainable by people. Would you